welcome to this explainer. Look, if you or maybe someone you know has ever dealt with the absolute maddening frustration of a recurrent urinary tract infection, you know exactly how exhausting it is. For decades, the medical approach just felt like a revolving door. You get a symptom, you take an antibiotic, you cross your fingers, and inevitably, boom, you're right back where you started a few months later. But here's the good news. Right now, we're in the middle of a massive fundamental shift in how medical science is actually approaching and understanding the bladder. Today, we're breaking down a recent clinical update that's pretty much changing everything we thought we knew about UTIs. To really get why this paradigm shift is so urgently needed, we have to look at what's happening out there in healthcare right now. In a recent analysis looking at over 1.2 million ambulatory visits, researchers found a staggering 325% increase in UTI encounters per 100 women. I mean, that is an absolute explosion in patients seeking help for urinary symptoms. And following right on the heels of that stat is this one, a 227% increase in antibiotic prescriptions for these exact encounters. This right here is the central tension of our explainer today. We've got a skyrocketing number of patients complaining of UTI symptoms and a similarly massive spike in broad-spectrum antibiotics just being thrown at the problem. But since recurrence rates are still a massive issue, it really begs a serious question about our current medical strategy.
Are we actually treating the wrong problem? Or at the very least, are we treating it the wrong way? The data actually shows that this dangerous spike in prescriptions has been heavily driven by the rise in virtual healthcare encounters, telehealth. Now, telehealth is incredibly convenient, obviously, but diagnosing a highly complex pelvic ecosystem over a quick video call, that has led to a major diagnostic blind spot. We're prescribing way more antibiotics than ever, and often without genuinely confirming what it is we're even treating.
Okay, let's dive into this. Section 1, the endless cycle.
To really grasp the magnitude of this problem, we need to ground ourselves in the clinical baseline. The standard clinical definition of a recurrent UTI is having 2 or more symptomatic episodes in 6 months or 3 or more in a single year. But here's the absolutely crucial caveat that constantly gets missed in a rushed telehealth appointment. These symptoms must be genuinely attributable to a confirmed infection. You can't just assume it. Conditions like genitourinary health symptoms of menopause, or GUSM for short, can mimic an infection perfectly. If you don't actually prove an infection is present, honestly, you're just guessing.
Which brings us to Section 2. The diagnosis trap, the danger of overlapping symptoms. And this brilliantly illustrates exactly why so many patients are getting trapped in this endless loop of misdiagnosis and unnecessary antibiotics. The female pelvic region is incredibly complex. Notice how true urinary tract infections sit right smack in the middle of this web, completely overlapping with entirely distinct conditions. You've got overactive bladder on one side, pelvic floor muscle dysfunction on another, and low estrogen at the bottom. Symptoms like painful urination sit right there in those overlapping gray areas. Over a quick phone call, it is nearly impossible to separate a true UTI from these mimicking conditions. This is precisely why we have to contrast the diagnostic pitfalls of virtual visits against standard in-person assessments. Virtual encounters rely pretty much entirely on symptom reporting, which leads directly to that massive spike in empiric antibiotic prescriptions we talked about earlier. But in-person assessments, they allow for standard urine cultures. A proper culture can accurately confirm a true UTI by looking for a specific threshold of bacteria, specifically 1,000 colony-forming units per milliliter alongside your actual symptoms. Without that culture, we're basically flying blind and risking some severe antibiotic overuse. Moving on to Section 3, your urinary microbiome, a living ecosystem.
So what exactly happens when we continuously throw antibiotics at a system blindly? Well, historically, medical science thought the bladder was a completely sterile environment. Turns out, we now know that is entirely false. It's a surprising fact, but it changes absolutely everything. A healthy genitourinary microbiome actually has this really delicate balance of native, protective bacteria like lactobacillus. But things like aging, repeated broad-spectrum antibiotics, and estrogen drops completely alter this microbiome. That healthy flora just gets wiped out, leaving the bladder super vulnerable to a hostile takeover from uropathogens. Now, what's really interesting about this next slide is where the science gets truly fascinating and, honestly, a little bit sinister. Bacteria like E. coli don't just float around in the urine. Nope, they actually invade the cells lining the bladder wall and form these hidden structures called intracellular bacterial colonies. Think of them almost like home invaders that break in and then lock the doors behind them, So just nuking the surface environment with a standard antibiotic totally fails to fix the root problem. Those hidden colonies survive, they eventually burst out, and fuel your next infection. Let's pivot to Section 4, Non-Antibiotic Solutions, Proactive Prevention.
This incredible new understanding brings about a major pivot, and honestly, it offers some profound validation for frustrated patients who've been seeking a way out of the antibiotic loop. It proves the problem was never just in your head and that relying solely on antibiotics was a fundamentally flawed strategy. As the source material highlights, quote, expanding knowledge about the urogenital microbiome is already leading to changes in the clinical management of patients. The whole focus is shifting away from reactive destruction and moving toward proactive protection, aiming to keep those hidden bacterial colonies from ever gaining a foothold in the first place.
Leading this preventative charge are some really specific, targeted tools. First up, cranberry. Evolving data shows this is definitely not just a myth. Specifically, its active ingredient, proanthocyanidin, with A-type linkages, actually prevents E. coli from binding to the bladder wall. If the bacteria can't bind, they can't form those hidden colonies. Simple as that. Similarly, D-mannose acts as a decoy sugar, which also blocks adhesion. And finally, methenamine hippurate. This is an antiseptic that inhibits bacterial growth right in the urine, but without nuking your systemic microbiome the way traditional antibiotics do. These are targeted mechanical defenses.
And finally, Section 5, Targeted Future Treatments. Now, of course, prevention isn't always foolproof. When an acute infection does break through and it's actually confirmed by a culture, we need a highly specific, modern intervention. We can't just keep throwing those same old broad-spectrum antibiotics at a highly resilient bacterial colony. Enter targeted treatments like Orlinva. This is a brand new, FDA-approved oral option for uncomplicated UTIs. Consisting of a targeted antibiotic pairing, sulopenem hexadroxyl with probenecid, it offers real hope for stubborn pathogens like E. coli, Klebsiella pneumonia, or Proteus mirabilis in adult women who have basically run out of alternative options due to resistance. It's a precise tool for a confirmed problem, and it's moving us far away from the era of blind prescribing.
So what does this all mean? The most absolutely crucial takeaway from all this clinical data is that you have way more power than that traditional endless cycle suggests. The science has evolved, and so our healthcare advocacy has to evolve right alongside it. The next time symptoms strike, before you just accept a blind prescription over a quick video call, ask yourself, will you demand an in-person culture? Are you just treating a symptom, or are you actually treating the root cause? Understanding your own biology really is the very first step in breaking the cycle. Thanks so much for joining me for this explainer.